Hello everyone. Today, Health Ninja talks about nephritic syndrome in children. Nephritic syndrome is a clinical syndrome present as hematuria, elevated blood pressure, proteinuria, oliguria, peripheral edema, and deranged renal function. Causes are post-infections such as streptococcal infections and other disease such as Staphylococcus aureus, Streptococcus pneumonia, Mycoplasma pneumonia, Escherichia coli, Epstein-Barr virus, cytomegalovirus, herpes simplex virus, varicella-zoster virus, hepatitis B and C, as well as parasites like malaria, schistosomiasis, leishmaniasis, and toxoplasmosis, fungal pathogens including Candida, Aspergillus, and Cryptococcus, and Rickettsia such as Coxiella and Legionella. Autoimmune disorders like systemic lupus erythematosus and ANC vasculitis, IgA nephropathy, mesangiocapillary glomerulonephritis, and rare cases like anti-glomerular basement membrane disease, Goodpasture syndrome. Furthermore, shunt nephritis, endocarditis-associated nephritis may rarely contribute to the development of nephritic syndrome. Let's talk about acute post-streptococcal glomerulonephritis briefly. Nephritic syndrome, prevalent among 5 to 12 years. It exhibits a male predominance with a 2-to-1 ratio and a higher incidence in lower socioeconomic groups. Pathogenesis. In streptococcal infection, the body forms antibodies against the bacteria. Some of these antibodies also react with similar structures on the glomerular basement membrane, and some antibody binds to the antigen and makes immune complexes which deposit in the glomerular basement membrane. These immune complexes activate the complement system, leading to inflammation. This inflammation damages the glomerular membrane, allowing protein to leak into the urine and causing other nephritic symptoms. Complications of the nephritic syndrome include acute kidney injury, hypertension, hypertensive encephalopathy, and heart failure. Investigations for nephritic syndrome include full blood count for anemia, urine, full report for dysmorphic red cells, and proteinuria, serum creatinine. Serum electrolytes for signs like hyperkalemia. ASOT, or throat swab, and anti-DNase B help identify streptococcal infections. Investigations for other potential causes. Imaging studies like ultrasound scan for polycystic kidney disease and renal tumors, X-ray for stones, and urine culture for infections. To evaluate complications, a chest X-ray may reveal features indicative of heart failure, including upper lobe diversion, a bat's wing appearance, curly bee lines, and pleural effusions. Indications for renal biopsy include the presence of features indicative of other nephritides, a rapid rise in creatinine, persistently elevated creatinine for more than 2 to 4 weeks, a mixed nephrotic-nephritic picture, significant proteinuria lasting more than 4 weeks, macroscopic hematuria persisting for 2 to 4 weeks, low complement levels after 12 weeks, and persistent hypertension. The clinical course typically involves diuresis within 7 to 10 days from onset, with blood pressure normalizing in 2 to 4 weeks. Macroscopic hematuria settles within 1 to 2 weeks, and significant proteinuria clears in 2 to 4 weeks. Renal function normalizes within 1 to 2 weeks, while serum complement levels return to normal in approximately 12 weeks. However, microscopic hematuria may persist for 1 to 2 years in some cases. In the management of acute post-streptococcal glomerulonephritis, supportive care is crucial. This involves monitoring blood pressure, fluid intake and output, daily weight, urine albumin, and renal function. Dietary potassium restriction is recommended in oliguric patients, while limiting salt and fluids is advised in the presence of hypertension or edema. Physical activity should be restricted in hypertensive individuals. As medications, oral penicillin. For hypertension, loop diuretics such as frusemide with or without calcium channel blockers are prescribed. In cases of hypertensive encephalopathy, medications like hydralazine or labetalol may be used. Patients can be discharged when urine output and renal function, blood pressure, and hematuria have normalized. However, close follow-up is important until the patient is off antihypertensives, followed by monthly monitoring until proteinuria clears. Subsequently, follow-up intervals can be gradually extended, but ongoing monitoring should persist until the urine sediment is clear. Thank you for watching. Subscribe for more videos.